Go.
Hey guys, my name is Hondo Anderson. I'm a student of physical therapy here at South College. I'm in the graduating class of January 2021. Today I'm going to show you a couple of techniques with my patient Jessi. We got the flexion-based thoracic manipulation and a couple of shoulder mobilizations that I'm going to be showing you. So to start with this flexion-based thoracic manipulation, we know that the thoracic spine has a kyphosis with a natural curve, and then below that curve, the way that the spine is formed, that's where this flexion-based technique works the best. It's going to allow us, for our line of drive of this force and the thrust, to line up with that spine perpendicular, making it the most effective. So for this manipulation, you're going to have the patient lie on their back. You're going to have them scooch to the edge, and they're going to bend this leg, and then go ahead and cross your arms. The first thing we're going to do is just test for, make sure they're not hypermobile. Jessi's got a little bit more mobility than I would like, so I am going to just tuck a towel in between, or a sheet between her arms, just to kind of take up some of that give, so it allows my thrust to go more towards my target segment and not be lost and eaten up in those arms moving. And it's also not going to injure her. So now that I've got that, I can retest. It's much more stable here. So I'm going to take this knee, I'm going to take Jessi, I'm going to let her know I'm right here to block her so she's not going to fall. I'll roll her towards me, and with this hand, my bottom hand, I'm going to find my target segment of the spine that I want to produce the neurophysiologic benefits. And with this hand, I'm making a fist, and I'm going to try to get it so that her spinous processes are lined up in this little crevice of my fist. Once it's there, I'm going to roll her back, and I'm going to have her crunch up so her elbows go just below my xiphoid process. I'm going to lean into her a little bit, find that barrier, and then from here, I'm going to lunge to deliver that thrust. And the lunge is at an angle, so again, so it's perpendicular to her spine, and it's not just dropping her straight down, which can crush her back on your fist and be uncomfortable for her and not produce the same results that we're looking for. So then now, as we go into the shoulder mobilizations, this one I'm going to show you is an inferior glide, and this would be beneficial for a patient, let's say they're having trouble reaching overhead, and the limitation can be caused by a couple of things, but one of them could be the arthrokinematics of the humerus on the glenoid cavity of the scapula. So we know, based on the convex concave rules, as we reach overhead, the roll is going up, so that the glide needs to go down. And if we're limited on that glide, we can get stuck and not be able to get overhead with our arm. So what I would do is I'd have the patient just test and just see what their overhead reach is. And we could take a measurement with the goniometer if we want to quantify it. And then we get into the mobilization. So for this mobilization, I'm going to take the arm, and I'm going to pin it between my arm and my body so she's totally relaxed. And I'm going to take my mobilizing hand, and I'm going to put it on the proximal part of the humerus, as high up on that humerus towards the head as I can get it. And then from here, I'm going to use my body to create these movements. Again, we can do grades 1 and 2 if it's our goal is to reduce some pain. But in this case, if the patient's limited in overhead reach and we want to work on the mobility, we would go more towards grades 3 and 4. So we'd find R1, get to R2, and then we'd do our grades 3 and 4 around the R2 barrier to improve that. Once we're done with that mobilization, we can reassess the patient, have her do her overhead reach. Again, we get the goniometer out, measure it, and see if we had any improvements from that. Thank you guys for your time. I appreciate it.